morning or good evening to all. Many thanks for your interest in this lecture, and thanks to the editorial office for inviting me. The topic of my presentation is sex differences in MASLD. And I have no conflict of interest to declare. My talk has three aims: analyze sex differences in epidemiology, clinical manifestations, and possibly response rates to treatment in MASLD, examine specific examples of how reproductive life affects the risk of MASLD in women and men, and try to explain these sex disparities in terms of physiopathological underpinnings. Sex and gender are not synonyms. Sex is a biological variable. Gender is a cultural construct based on different roles, responsibilities, attributes, and entitlements that exhibit intercultural disparities and are modifiable over time. Lifestyle habits such as alcohol intake, dietary preferences, attitudes to practicing sports and physical activity, willingness to submit to preventive medicine and other factors vary according to gender and may impact on the risk of liver fibrosis. However, these gender-related variables are out of the scope of my presentation. MASLD is the latest of various nomenclatures that have been utilized over time. MASLD has in common with NAFLD the exclusion of competing etiologies of steatosis, while sharing with NAFLD the positive diagnostic criterion. Today, I will use MASLD and NAFLD in agreement with the studies that are cited. Available evidence indicates that MASLD and NAFLD identify the same patient population with overlapping disease trajectories. The prevalence of MASLD is significantly higher in men than in women. However, after menopause, the protective effect of the female sex diminishes, indicating that sex and reproductive status are important considerations when studying. Not only the development of NAFLD is influenced by sex and reproductive status, but also disease progression. In this seminal meta-analysis of 54 published studies, Balakrishnan found that women had approximately 20% reduction in the risk of NAFLD compared to men. However, if we look at the risk of NASH, no significant difference was identifiable in women compared to men. And finally, women were exposed to a 37% higher risk of fibrosis than men. Importantly, age modified the effect of sex on NAFLD severity. The risks of NASH and advanced fibrosis were substantially higher in women aged 50 years or more, and sex differences in NASH and advanced fibrosis were attenuated in younger populations. However, the question is, what happens once cirrhosis is established? She et al. Performed a population-based retrospective cohort study of adults with cirrhosis, and males compared to females had a statistically higher incidence of decompensated cirrhosis, hepatocellular carcinoma, and liver transplantation, indicating that the male sex is probably associated with worse liver-related outcomes among those with cirrhosis owing to variable etiology, notably including cirrhosis. And what about the risk of MASLD-related cardiovascular disease? A recent meta-analysis shows that MASLD is associated with a significantly higher risk of fatal and non-fatal cardiovascular disease events in women than in men, suggesting that muscle probably abrogates the protection from cardiovascular disease in women. Moreover, in muscle, breast cancer, colon cancer, and pancreatic adenocarcinoma occur 24% more often in women than in men, and the risk of their occurrence does not depend on the stages of liver fibrosis. Conversely, hepatocellular carcinoma occurs more often in men than in women, and is directly related to the risks of the stages of liver fibrosis, although it may also develop in the context of non-cirrhotic muscle. These data, together with those related to cardiovascular events that have been shown in my previous slide, indicate the burden of muscle-related extrahepatic outcome is probably higher in women than in men. Pathogenic models of muscle have evolved over time. Here you see that the body fat distribution, specific biology of adipose tissue, and gut microbiota play a key role. However, more recent perspectives have pinpointed that postmenopausal women indicated by violet arrows behave similarly to men who are shown by blue arrows with respect to the key pathogenic steps in muscle development and progression, whereas premenopausal women who are indicated by red arrows behave, are protected from muscle due to estrogens via estrogen receptor alpha, increasing the catabolism of fatty acid and their export from the hepatocyte into the bloodstream, while downregulating endocrine and steatogenesis, oxidative stress, inflammation. The question is, where do these prominent sex differences originate? The temporal pattern of pituitary growth hormone secretion is a sex-specific in many species, namely it is episodic in males and more stable in females, representing a major component in establishing and maintaining the sexual dimorphism of hepatic gene description. If it otherwise, we must think of the male liver and the female liver. This sexual dimorphism of liver transcriptome becomes apparent in the ovariectomized mouse model, and more importantly, in severely obese women aged more than 51, suggesting that masculinization of the female liver contributes to muscle development in obese women of menopausal age, pointing to a hepatic estrogen receptor alpha as a potential pharmacological target for preventing muscle among post-menopausal women. Complex interactions between growth hormone, estrogen, and androgen signaling determine sex and reproductive status specific variations in the deposition of body fat, which are artistically adipose tissue distribution, which is called an android adiposity, opposed to a premenopausal gynoid body fat distribution, which is typical of goddess Venus. However, in panel B, we also see the functional correlates of these clinical phenotypes, indicating that visceral adiposity promotes hypertriglyceridemia, whereas subcutaneous body fat has the potential for oxidation of fatty acids to ketone bodies, browning of white adipose under metabolically stressful conditions, for example, fasting and exposure. However, after menopause, women may accumulate visceral adipose tissue with an android type pattern, explaining why the risk of progressive muscle increases. We also have to consider that sex interacts with two among the main gene variants. The PNPLA3 148M gene variant determines a gain of function and therefore is associated with an increased risk of muscle cirrhosis and liver disease progression. And as we will see in the next slide, this deleterious effect on liver histology higher in women than men. These are women, these are men, these are women, these are men, and this is the risk of MASH, this is the risk of clinically significant. Conversely, the hydroxysteroid dehydrogenase 17B13 variant is a loss of function variant which is associated with the decreased risk of cancer. This protective effect is more evident in post-menopausal women, such as shown by this graph, which indicates that the risk of steatohepatitis in women starts to be statistically significant only after the age of 50, because in earlier ages, women are already protected by estrogens. Conversely, as you can see in men, these differences, the statistical difference between these two curves becomes across the entire lifespan. The liver shows remarkably diverse cellular composition and functional organization. Logically, while lobules are the liver structural units, the hepatic acinus is the liver's functional unit, especially with respect to blood flow, oxygen gradient, and nutrient concentration. In panel C, you see illustrated the notion of metabolic zonation, namely a zone-specific distribution of enzymes and metabolic pulsatile growth hormone release predominantly activates signal transducer and activator of transcription 5B, STAT5B signal, and drives periportal gluconeogenesis, beta oxidation, and cholesterol biosynthesis in males. Whereas the continuous growth hormone profile favors STAT3 activation, which together with other factors contributes to the localization of lipogenesis and xenobiotic metabolism in a pericentral position in him. Further to metabolic zonation, sex differences in muscle comprise gut microbiome. Evidence in humans is limited. The study has found that key microbial taxa in women included Christensenella enhanced in pulse and Limosibacillus enhanced in muscle. And in men, Beduinebacterium was depleted in muscle, whereas Anaerotrombus was enhanced in muscle. Although these findings await further confirmation, they are key proof of evidence that indicating that a sex-specific precision medicine approach is potentially available in muscle. Given the paucity of investigations in humans, the study I am presently showing you implemented interpretable machine learning models to classify muscle status and biological sex from human gut microbiome databases. Findings indicate that variations in specific bacterial phyla may modulate the risk of fibrosis, inflammation, and dysbiosis in a sex-specific manner, suggesting that microbial composition may contribute to disease trajectories. While the sexual dimorphism of adaptive immunity remains understudied, in muscle, innate immune cells responses significantly different between men and women. In men, owing to increased androgen signaling, increased pro-inflammatory macrophage responses, and increased infiltration of neutrophils and monocytes are observed in the liver. Increased androgen receptor signaling might also explain the higher prevalence of NASH in polycystic ovary. Polycystic ovary syndrome affects up to 10% of reproductive aged women who exhibit obesity, hyperandrogenism, chronic anovulation, infertility. Liver involvement is common in cause. These individuals are also at increased risk of NASH, irrespective of metabolic comorbidity. Two recent studies, one by Liu, who performed a bidirectional two-sample Mendelian randomization analysis, and who performed the meta-analysis of 24 studies, collectively demonstrate that mild causes caused by a visceral adiposity, decreased insulin sensitivity, and increased testosterone levels. It is also important to consider that menstrual and reproductive factors, as well as the use of exogenous hormones, modulate NAFLD risk. A nested case control study has shown that while increasing age at menarche protective, parity regardless of number of children or age at first birth, surgical menopause compared to natural menopause, oral contraceptive use, and longer duration of estrogen menopause hormone therapy were all linked with an increased risk. Confirming these findings, another study by C et al. Has shown a linear association between age at menarche and risk of NAFLD. And this author, through a Mendelian randomization analysis, have also demonstrated that for each additional year of age at menarche, the incidence of NAFLD decreased by around 20%. And the reverse Mendelian randomization analysis also showed that age at menarche causes NAFLD unidirectionally. Meta-analytic evidence also confirms that menopause is a strong risk factor for NAFLD, with a pooled odds ratio of 2.37, irrespective of age and metabolic factors, raising the question of what effect estrogen replacement therapy might have in menopause. The prevalence of NAFLD, identified with ultrasonography before and after menopausal hormone therapy, varies depending on the route of estrogen. Here you see that the prevalence before treatment was in the order of 24% or 25%, without any significant differences in women assigned to receive transdermal or oral menopause hormone therapy. However, after treatment, the prevalence of NAFLD decreased from 24 to 17% the transdermal group, while increasing from 25 to 29.4% in the oral group. Finally, you also see that the progression of disease, the proportion of progressive disease comprising both newly diagnosed or worse severity of disease decreased after transdermal estrogen administration. How can these seemingly inconsistent data or difficult to combine data, how can be assembled together into a coherent theory? The theory that can be put forward states that physiological estrogen levels are necessary for maintaining liver health in both sexes, and in males, both low and high estrogen levels are invariably associated with perturbed metabolism of glucose and fatty acid. And in the same manner, normal testosterone levels maintain liver health, whereas in males, low testosterone levels and in females, hypertestosteronemia will invariably be associated with steatogenic liver disease with similar with similar mechanisms affecting intermediate metabolism. I also want to highlight that estrogen and androgens influence all resident cell types in the liver. For example, you see how estrogens undoubtedly act on hepatocytes, promoting DNA synthesis, but they also are active on sinusoidal endothelial cells by promoting synthesis of However, as you can see, estrogens are powerful inhibitors of the inflammatory reaction because they inhibit the secretion of IL-6, interleukin-6 from Kupffer cells, and they also block or inhibit the synthesis of fibrogenic. Conversely, androgens increase mitogenic activity of hepatocytes and stimulate angiogenesis acting sinusoidal endothelial cells. However, at variance with estrogens, they are strongly promoters of IL-6 secretion per cells, and this particular physiopathological aspect seems to explain why men are at increased risk of hepatocellular carcinoma compared to women. Additionally, androgens are also progenic, which is also another mechanism in the risk of hepatocellular. Further to sex chromosomes further to sex hormones, also sex chromosomes metabolism. The four core genotype mouse model schematically illustrated slide allows the interrogation of independent effects of sex chromosomes and gonadal by generating four distinct phenotypes. Combination of SRY trans gene that specifies the development of testes and XY or XX chromosomes. But the question is whether or not studies are relevant to clinical medicine. As a clinician, I would like to briefly mention Turner syndrome and Klinefelter syndrome on sex chromosome aneuploidies in clinics. Here you see that Turner syndrome results from a conflict of one of the X chromosomes in biologically female subjects, one denoted 45X. Conversely, Klinefelter syndrome exhibits a karyotype featuring double XY share in common that both exhibit an increased risk of metabolic syndrome, of hypogonadism, and of steatotic. Of interest, Klinefelter syndrome is metabolic derangements and probably also the disease itself is strictly associated with X chromosome. This is shown by the fact, for example, that increased abdominal obesity and insulin resistance are observed in Klinefelter syndrome before the onset of puberty. In agreement, testosterone restoration does not fully mitigate metabolic abnormality in Klinefelter. Let us now examine the effects of estrogen replacement therapy on Turner syndrome. Here you see this small size and quite old study that increasing dosages of oral estradiol resulted in a decreased levels of serum enzymes. However, we also have to consider that expert opinion presently suggests that 17 beta estradiol be administered via transdermal route as the preferred option to prevent the risks of potentially harmful liver metabolites in the oral route. Now let us examine the impact of muscle on the mother and infant diet in the context of pregnancy. Meta-analytic evidence highlights that enough patients have a statistically increased risk of gestational diabetes mellitus and preeclampsia. As for fetal outcomes, being that enough patients are significantly likely to have premature birth and large for gestational birth, indicating that enough is associated with poor pregnancy. Conversely, breastfeeding protects both the mother and the infants against development and progression of MAST. Lactation is deemed to be roughly equivalent up to 30 minutes of running and assists resetting the metabolic alterations that occur during pregnancy, protecting lactating mothers from the risks of insulin resistance, diabetes, and metabolic syndrome. Also, the infants are protected from associated with fibrosis via colonization and development of the gut microbiota of the epithelium and immune systems. Moreover, docosahexaenoic acid in human milk and milk-derived cellular vesicles inhibit lipogenesis and profibrogenic. The last section in my slides regards sex-specific disparities in muscle response rate to treatment. This was probably first published 10 years ago by Villar Gomez et al., who studied individuals who were encouraged to adopt recommended lifestyle changes aimed to reduce their body weight over a 1-year time span. These authors found that together with other metabolic liver histology features, the female sex was a predictor of reduced probability of NAS improvement. May I remind you that NAS indicates NAFLD activity score. It is defined as the unweighted sum of the score of globular inflammation and ballooning. Interestingly, more recent studies confirm that men compared to women probably exhibit better response to dietary interventions in terms of weight loss and metabolic improvement. Regarding sex differences to drug treatment, meta-analysis of 14 studies has shown that women treated with various glucagon-like peptide receptor agonists, which are listed in the title of the study. These ladies lost more weight than men, and meta-regression demonstrated as the degree of weight loss increased in parallel when the total weight reduction increased, the sex differences also increased. Various putative mechanisms may explain these sex differences in response to GLP-1 receptor agonists in women and men, and these comprise pharmacokinetic differences, increased satiety, more significant improvement in pathobiology and more stringent compliance to treatment, which is line of research may potentially have innovative treatment avenues. I will illustrate here how a stable GLP-1 estradiol conjugate was developed to selectively deliver estrogen to cells expressing the GLP-1 receptor without causing unwanted side effects while maximizing their efficacy. However, it is worth pinpointing laboratory studies with this compound are conflicting, and there are no published data studies in humans. Now let us go to examine the effects of testosterone replacement therapy in a hypogonadal man. Recent systematic review with meta-analysis suggests improved liver outcomes without any additional adverse events. However, in my opinion, more studies are needed to overcome limitations inherent in published studies owing to different testosterone doses, routes, and frequencies, variable risk of bias, different study designs, and follow-up. Finally, a novel line of research regards gender-affirming hormone therapy that is used in transgender individuals, and this line of research might also offer some useful information. As this slide illustrates and summarizes, magnetic resonance imaging and spectroscopy study, including 15 transgender women and 20 transgender men, showed some relevant changes in the body fat distribution because the ratio of visceral adipose tissue to cutaneous adipose tissue is the case of a transgender woman before treatment and after gender-affirming therapy. You see there was a significant expansion in the subcutaneous adipose tissue. However, there were no significant changes in liver fat content. So this is a promising line of research, but more data are necessary. In conclusion, sex differences occur in the reproductive life in men and women and characterize epidemiology, pathogenesis, medical outcomes, and response rates to treatment. These prominent sex differences are due to the coordinated interaction of sex chromosomes, and modulate muscle development and progression by modifying disease pathobiology. Prominent sexual dimorphism should be constantly considered in all mass studies and trials. Thank you for your attention.